Well, good evening, everyone, and welcome to this BTOG Masterclass entitled Immunotherapy Tips and Tricks. This is one of a series of webinars that we're hosting in BTOG for your greater education and experience. My name is Sanjay Popat, and I'm the chair of the BTOG Steering Committee and medical oncologist at the Royal Marsden Hospital. Now, remember, all the work that we do in BTOG, whenever it's sponsored, the sponsors of this particular activity and the BTOG events do not have any role whatsoever in the planning, content, or delivery of the material that's being presented. I'd like to give you all a very warm welcome, those of you that are able to join us live, and those of you that are listening to this on your podcast. And just to remember that our executive team, Dawn and Gina, are available either at info@btog.org or via the website for all of your needs from the BTOG viewpoint. So a few aspects of housekeeping. We like to keep this as interactive as possible, so please do submit your text questions in the chat box, and they'll pop up and we'll be able to post them to our speakers. Now, today we're going to have a very live interactions discussion more than anything else. So do pop your questions in as they arise. Don't just wait for right at the end. As you've got a bright idea, put your question in and we can take that throughout the course of the evening. We will send you an email for your feedback, and your feedback is, as ever, really important to us, and this will also trigger a certificate of attendance. Participants that are listening to this using the archive version on a podcast, you can record it in your CPD diary from the Royal College of Physicians using the approval code 138552 for up to 4 weeks after the event date, which is up till the 6th of January. So today we're going to have three excellent speakers talking about immunotherapy and thoracic malignancies. My colleague Rafaelle Califano is going to be talking about small cell. My colleague Shobhit Baijal is going to be talking about non-small cell. And my colleague Joanne Evans is going to be talking about immunotherapy toxicities, a really tricky and thorny issue. We're just going to have a brief overview, and then we're going to have a lot of discussion for the remaining half an hour of the meeting. So overall, initially, I'm going to move over to my colleague, Rafaelle Califano. Rafaelle, come online and speak to us about immunotherapy in small cell.
Thank you very much, Sanjay, and thanks for all the colleagues who are joining us for this educational event hosted by BTOG. It's my privilege to be here. Small cell lung cancer is a very aggressive disease, and sadly, the addition of immunotherapy to the first-line armamentarium has been very welcome. Over the next minutes together, these are my disclosure, I'm going to give you a brief background about the current situation for small cell lung cancer, but then I will focus on the data that supports the use of first-line chemoimmunotherapy, and in particular, I'll try and discuss with you the potential role of any biomarkers to select patients most likely to benefit. I will then conclude, and I'll be very happy to take your questions during the discussion later on. Small cell lung cancer is a very aggressive disease. Despite the excellent responses to first-line platinum etoposide, we all know that these responses are usually short-lived. And when we transition to second-line chemotherapy, it's unfortunately a very difficult situation for our patients, as we know that this has, unfortunately, very limited clinical efficacy. It's not uncommon in clinical practice to re-challenge our patient with platinum-based chemotherapy if they have platinum-sensitive disease, which is defined as having a time to progression of at least 3 months since the last cycle of chemotherapy. But what about the use of first-line immune checkpoint blockade? The first trial that was presented evaluating this strategy is IMpower 133, which is a large phase 3 randomized clinical trial, evaluated patients with untreated extensive stage small cell lung cancer with a good performance status, who were randomized in a 1-to-1 fashion to carboplatin etoposide and placebo for 4 cycles, or carboplatin etoposide and atezolizumab for 4 cycles, followed by atezolizumab or placebo as a maintenance setting until progressive disease or loss of clinical benefit. The trial had 2 core primary endpoints: overall survival and investigator assessed progression-free survival. As part of the trial design, patients enrolled in both arms could receive prophylactic cranial radiation, but consolidation radiotherapy to the chest was not allowed. The trial at the first data cutoff was a positive study demonstrating a longer overall survival favoring the chemoimmunotherapy arm over the standard carboplatin etoposide, with a median overall survival of 12.3 months versus 10.3 months and another ratio of 0.7. If you look at the 12 months overall survival rates, this was clearly higher in the chemoimmunotherapy arm at 51% versus 38% for the standard carboplatin etoposide arm. The authors also presented data on overall survival with a longer follow-up, this time nearly 23 months, and there was a consistent benefit favoring the chemoimmunotherapy arm in terms of overall survival. If you focus your attention this time on the 18 months overall survival rate, it was very important to see that this was still higher in the chemoimmunotherapy arm, this time at 34% versus 21% of patients still alive at 18 months, favoring the atezolizumab arm. But what about the summary in terms of safety for these patients? It was very important to see that the addition of atezolizumab to standard carboplatin etoposide didn't increase the incidence of treatment-related adverse events or serious adverse events. It goes without saying that there was a higher incidence of immune-related adverse events in the chemoimmunotherapy arm, with approximately 10% of patients who had to withdraw treatment due to adverse events which were related to atezolizumab. The median duration of treatment with atezolizumab in this trial was less than 5 months, with the median number of doses for the immunotherapy part of 7, with a range between 1 to 30. Almost all patients had 4 cycles of chemotherapy as a backbone. If we have a more in-depth look at the adverse events, again, I think it was reassuring from a clinical point of view to see that addition of atezolizumab to carboplatin etoposide did not increase the incidence of bone marrow toxicity. If you look at the immune-related adverse events, these were more frequent in the atezolizumab arm, of course, and these were mostly rash, hepatitis, infusion-related reaction, together with pneumonitis, colitis, or pancreatitis. The vast majority of these immune-related adverse events had the grade of 1 and 2, and if you look at the grade 3 or 4 in terms of incidence, this was around 2% for rash, hepatitis, and reactions, and less than 1% for pneumonitis, which is an adverse event which is relevant for clinical practice. Another study to evaluate the chemoimmunotherapy strategy in extensive stage small cell lung cancer is the Caspian study, this time 3 arms, untreated extensive stage small cell lung cancer patient, good performance status, randomized to receive platinum etoposide up to 6 cycles, and this time was dealer's choice, either carboplatin etoposide or cisplatin etoposide. The investigational arms had 4 cycles of the platinum etoposide backbone plus durvalumab or plus durvalumab and tremelimumab. For patients who were randomized to the standard chemotherapy arm, there was the option of prophylactic radiation up to after 6 cycles of treatment. For patients who were randomized to the investigational arms, there was the maintenance phase with durvalumab every 4 weeks until progressive disease. The primary endpoint of this study was overall survival, and it's important to point out that this study did not allow prophylactic cranial radiation in the investigational arms and also did not allow consolidation radiotherapy to the chest in the study. The study was a positive study demonstrating that the combination of durvalumab plus platinum etoposide was superior in terms of overall survival to standard chemotherapy. This was not seen as there was no statistically significant advantage for the durva-tremi EP arm. This is the 2 years overall survival data where the median for the durva EP arm was 12.9 months versus 10.5 months with an hazard ratio of 0.75. It's always important to look at the long-term impact. So if you look at the Kaplan-Meier curves, the 24 months overall survival rate was around 24% for the durva EP arm versus only 14.4% in the standard chemotherapy arm. Very recently, only a couple of months ago at the ESMO Congress, Professor Pazares presented the data with 3 years overall survival And there was a consistent benefit favoring Durva EP versus EP with a median follow-up of nearly 40 months. What was very impressive to see was that at 36 months, 17% of patients in the chemoimmunotherapy arm were alive when compared to only 5% for patients in the standard chemotherapy arm. And this is something that we would never expect a number of years ago for patients with extensive stage small cell lung cancer. Looking at safety, this is the table that summarizes the serious adverse events for the 3 arms. If you focus your attention on the Durva EP arm, which was the winning arm, you could see that the vast majority of the serious adverse events were related to bone marrow toxicity with febrile neutropenia on top. And if you look at the treatment-related adverse events which led to death, this was 2% in the Durva EP arm versus less than 1% in the standard chemotherapy arm. Looking at the immune-related adverse events, which are very relevant for this talk, this table summarizes the most common immune-related adverse events together with the time to onset. On the left-hand side, in blue is the Durva EP arm. The most common immune-related adverse events were pneumonitis, thyroid disturbances, type 1 diabetes, together with rash and colitis, of which grade 3 and worse was pneumonitis, which only 1%, type 1 diabetes grade 3 or worse was 2%, together with hepatitis. So this is something that is relevant for our patients in clinical practice. And what was important to see was in terms of time to onset, the quickest one to onset was usually the rash and the colitis, followed by thyroid disturbances, with pneumonitis arising up to 6 to 8 months, up to a year after starting treatment. So despite the addition of chemoimmunotherapy may have a very good impact on patients' outcome, the reality is that half of the patients will progress within 6 months of treatment. So the relevant question in clinical practice is, can we select our patients using any biomarker to have an idea about who is most likely to benefit? And I will run through the subgroup analysis evaluating different biomarkers in this study. This is the forest plot for IMpower 133, where the authors presented also the impact of the blood tumor mutational burden on overall survival using 2 cuts, 10 mutation per megabase and 16 mutation per megabase. And you could see that unfortunately we're not able to use blood TMB to select patients most likely to benefit. They also presented the impact of PD-L1 expression on overall survival. This is a post-hoc analysis, as the sample was not mandatory for PD-L1 expression. And if you look at the forest plot using a cutoff of more or less than 1% or more or less than 5%, you can't use PD-L1 to select patients most likely to benefit. So patients should be treated independently on the PD-L1 expression. They also reported, very interestingly, on the impact of blood TMB and PD-L1 on the long-term survivors, which are defined as patients who lived for at least 18 months since randomization. And if you look at these tornado plots, there is absolutely no difference in terms of impact on overall survival from Atezzo using blood TMB or any PD-L1 expression cutoff. This is very similar data from the Caspian study, again, looking at overall survival and PD-L1 expression, this time on immune cells and tumor cells with a cutoff of more or less than 1%. Durvalumab plus EP was associated with improved overall survival compared to standard chemotherapy, regardless of any PD-L1 expression using a 1% cutoff. The authors also presented the impact of this time tumor mutational burden. On the left-hand side, I've highlighted the Durva EP versus EP, and again, no difference using different cutoff from 10 to 14 mutation per megabase. So what is the message that I would like you to take home is that certainly first-line platinum etoposide plus atezolizumab or durvalumab is a new standard of care for selected patients with extensive stage small cell lung cancer. Unfortunately, there is no biomarker or clinical characteristics that can help selecting patients most likely to benefit. In my clinical experience, the toxicity profile seems to be very similar to what has been reported in non-small cell lung cancer studies for these agents, and also the delivery of prophylactic cardiac radiation and thoracic radiotherapy with immunotherapy seems to be safe. Thank you very much.
Great. Thank you, Rafaelle. Thank you for that overview. And I'll now move on to my next colleague, who is Dr. Shobhit Baijal, who's a consultant medical oncologist at Birmingham, who's going to briefly overview immunotherapy, non-small cell lung cancer, key points. Over to you, Shobhit.
Thank you, Sanjay, and thank you everyone for listening in. So this is going to be a whirlwind tour in terms of immunotherapy in the non-small cell lung cancer setting, kind of clinical applications, but evidence-based. Right, and we're going to go through this stage-wise. I'm going to start at the bottom of the ladder with the palliative setting, which is where immunotherapies first enter the non-small cell landscape and where the most evidence base and clinical application lies. And then we'll move up the staging ladder to see where it's now being incorporated in terms of earlier stage disease. First of all, I'm just going to talk about biomarkers. So Rafaelle talked about, there are different biomarkers out there, TMB, as Rafaelle talked about, and PD-L1. But really, I just want to break this down to keep this very simple. In terms of non-small cell lung cancer, the real, the clinically applicable biomarker at this current point in time is PD-L1. And we can measure PD-L1 on different areas, but we're talking about PD-L1 on the tumor cell. And we, for clinical purposes or treatment purposes, we break this down into three categories. The PD-L1 high expressors, that's 50% and higher. The low expressors, 1 to 49, and those are PD-L1 negative or unknown. And in terms of the treatment landscape, I'm going to use, I've pinched these from the NICE website, and these are quite nice algorithms to really take us through the treatment options for or how immunotherapy has incorporated itself into the non-small cell lung cancer environment. And again, to say very similar to what Rafaelle was saying about small cell, I mean, about 5 years back, this algorithm looked very simple. We only had old school chemotherapy with, pretty poor outcomes. So immunotherapy has completely shaken that up, and we've got, a whole different landscape now. So in terms of PD-L1 first line treatment, we're going to first focus on those high expressors. That's PD-L1 high, that's 50% or more. And yes, histology does matter for treatments, but principles in terms of how the treatments are administered are pretty similar for the squamous and the non-squamous population. In the non-squamous, we're talking about patients without driver mutations. And so for these patients, the evidence base is telling us that we can treat these patients, the majority of these patients, with single agent immunotherapy, pembrolizumab, and more recently we've got atezolizumab approved in this setting. And as I said, it's the majority of patients. There are some patients where we need to up the ante a bit more and go with a slightly more aggressive regime with chemotherapy and chemotherapy added into the immunotherapy, but that adds to the toxicity burden. So for the majority and where we can, we will go with single agent immunotherapy. And the evidence base for that comes from the Keynote 024 study. And I've got the PFS and OS Kaplan-Meier, and you can see the hazard ratio is significantly in favor here for pembrolizumab. But really, I think the eye-catching data is the 5-year overall survival data, which is showing us that about a third of patients are still alive at 5 years. And this is outcomes that were probably inconceivable before the advent or before the introduction of immunotherapy in this landscape. And that does correlate with clinical practice. This isn't just clinical trial, the world of clinical trials. If you have a high PD-L1 patient, we'll talk about PD-L1 as how good a biomarker it is. But once you've got past that 3 to 6 month mark of a positive scan, you can usually take from a clinical efficacy perspective, at least, take your foot off the pedal, and patients tend to do well. So it does correlate with practice, and we're almost changing this condition for this subgroup of patients into a chronic disease. And I say it with hesitation, but are we potentially curing a small subgroup of these patients? What do we do? So then the other side of the algorithm, so we're now looking at the PD-L1 low patients. So that's less or low or negative, that's 50% or lower. And for these patients, we need to up the ante to try and get that benefit of the immunotherapy. And that means using combination of immunotherapy and chemotherapy. So the principles remain the same between the two histological subtypes. But we do use different chemotherapy backbones. So for our non-squamous population, we use platinum pemetrexed, which I would say is more palatable. Our non-squamous tend to be fitter. These are tougher treatments than immunotherapy on its own. But for the squamous population, we're talking about a carboplatin paclitaxel backbone chemotherapy backbone. Doses which are pretty high. It's not a chemo regime that was very prevalent in the UK, and the doses are a little bit higher of what we're normally used to. And sadly, our squamous patients, as we know, tend to carry more comorbidities, can be of a lower performance status. So there are not as many squamous patients may be fit enough to take on this regime. It is a tough regime, but definitely a good performance status fit patients. That this is going to be the treatment that we're going to be aiming for. And the data for this, we've got two studies. We've got the Keynote 189, which is focused on the non-squamous population, and Keynote 407 on the squamous population. And again, we're seeing clear separation of the curves on the Kaplan-Meiers in benefit for the IO chemo combinations, with a suggestion of improved hazard ratios as the PD-L1 levels go higher. There are other first-line treatment options. There's the quadruplet of the Empower 150, based on the Empower 150 study. And what does that brings bevacizumab, the VEGF inhibitor, into the chemo IO cocktail. A complex study. Does it really add much more to chemo pembro? In my opinion, not really. Where it does stand out on its own is its data in the EGFR mutated population who progressed on their TKIs. And for me, that's probably where this treatment, where I would be looking at applying it into my clinical practice. Again, it's a toxicity-wise, it's a tough regime. Logistically, it's a tough regime in terms of day unit time. So, its utilization is limited, in my opinion, to that subgroup of patients. What about other IO? Adding in other classes of checkpoint inhibitors as CTLA-4 inhibitors. This has been explored in the Checkmate studies, in Mystique. Again, complex studies, multiple arms, different regimes. Again, breaking it down, in my opinion, probably doesn't bring a huge amount more to what we've already got available. And so potentially for me, it's not really something applicable. Suggestion maybe in the Checkmate studies that the PD-L1 negative patients do get an added benefit from the CTLA-4 PD-1 inhibitor combination. But as I said, from my perspective, in terms of application, it probably is with the pembro chemo combinations. What do we do? Second line? Well, second line is where the immunotherapies first came into play in our non-small cell lung cancer landscape. And there was an array of studies using the different IO agents, comparing them against docetaxel. And they were clearly superior and incorporated in our clinical practice. But as they've migrated to the first line setting, in my usage in the second line has dropped dramatically. I rarely prescribe IO in the second line because, from my perspective, if you've got a fit patient, well patient with no contraindications to immunotherapy, they should be receiving it either single agent or in combination in the first line setting. And we're not in a paradigm of re-challenging with immunotherapy. So that one hit is in the first line setting. So yes, it is available. It's available with different agents, with different kind of minutiae in terms of PD-L1 expression. But as I said, my usage has significantly dropped off. The only patients really where I may not be using an IO in that first line setting is where they've got a contraindication to it. And in that case, I'm not going to be using it in the second line. If we just move up the staging ladder, so stage 3 patients, classically, this is non-operable patients treated with chemoradiotherapy. Historically in the UK, we were very sequential chemoradiotherapy heavy, with outcomes of, or variable clinical outcomes. But, we weren't really achieving a great deal in terms of benefit for these patients. And there hadn't been any great gains for decades for that population. And that moves us to the Pacific clinical trial. So this was a phase 3 study for patients who'd had concurrent chemoradiotherapy for non-operable stage 3 non-small cell lung cancer, and were then randomized 2-to-1 to receive either durvalumab for 12 months or placebo. And quick snapshots of the primary endpoints of PFS and OS, as you can see, were significantly in favor for the durvalumab treated arm. And there is now longer term data again showing that these benefits are maintained long term. And this has completely revolutionized how we manage stage 3, both in terms of the clinical outcomes we can achieve with durvalumab, but also forcing our hand to make the correct switch in the UK from sequential chemoradiotherapy to concurrent where it's appropriate. Neoadjuvant, I'm not going to say much here because at this point in time, there's no, in terms of reimbursed application, but this is an area of high trial activity, using either immunotherapy on its own or immunotherapy in combination with chemotherapy prior to surgery. Early readouts are showing quite a bit of benefit. So I think the landscape in this setting, in my opinion, is likely to change in the coming years. And I'm hopeful we'll have some sort of treatment options incorporated in the near future. And finally, adjuvant setting. So I think it's fair to say that we've really not helped our surgical colleagues out over the years in terms of adding to the benefit of their surgical resections. We've been using platinum doublet chemotherapy for decades with very modest benefits of kind of 5 to 10% survival gain at 5 years. But now we've got the Empower 010 study, which explored atezolizumab given after the adjuvant chemotherapy for 12 months. And for the PD-L1 positive group, we're seeing a reduction, 34% reduction in the risk of disease recurrence. And hopefully this will be a treatment option we will have available in the near future. Take-home messages, things I've learned. First of all, biomarkers. I think the first thing to stress is PD-L1, it's not a clean biomarker. It's not like having a driver mutation. It's high expressors may not respond, low expressors can respond. So it's not a clean science. There's tumor heterogeneity, there's variability in how it's read, but it's the best we've got. Treatment selection, as I said, the algorithms look neat, but we've got to factor in the patient and, more important, their disease characteristics, their burden of disease, their rate of progression to determine how aggressive we need to go with the treatment. Again, I keep using the analogy of driver mutations. We're in that mindset where you've got a biomarker, you start somebody on treatment, you expect the tumor to melt away by the first scan. Now, immunotherapy is slightly different. We don't always see those responses. And I think it's about managing patients' expectations. That the disease you may not get a RECIST criteria partial response, but we're here for the long game, and even that disease control can still be durable. There's a lot bantered about pseudoprogression. Yes, I have seen it, but I don't think it's as commonly, or I've definitely not in my practice as commonly as I've seen. So I think be wary of getting too bogged down with these things. I think really assess the patient formally, make sure with that scan that you're interpreting it with how the patient is doing clinically. But that doesn't stop this treatment on progression, and definitely patients are gaining are clinically well or gaining clinical benefit, I will treat on progression. I don't want to run into my 10 minutes, but I think, steroids, it's a tough, difficult topic. There is, understandably, with steroids being immunosuppressive, there is a concern that they will dampen down the effects of immunotherapy. And there are a lot of data out there, meta-analyses looking at steroid use when patients start immunotherapy, and these patients do less well. But that could be confounded by the fact that they may have other factors that are affecting their prognosis for the reason why they are actually on steroids. But yes, definitely my aim is to get patients on either zero steroids or as low as possible before starting immunotherapy. And if they are on steroids and you've really got to think what else is going on here, and potentially be going with a more aggressive regime. Brain mets kind of feeds into that steroid issue, because again, if patients have got symptomatic brain mets, they're likely to be on steroids. And it really is a complex area, and one where it's a game with the clin-oncs about how we treat them, get the steroids down in time for treatment. But I know the next talk's about toxicity. One thing I would say is toxicities, as you might hear shortly, can take a while to settle down with prolonged courses of steroids, but that's a different paradigm than patients starting their treatment on steroids. But what I would say is it can be a nervy time because patients can be off treatment for a long period of time. But what we see, or what I tend to see, is that if they're in that 3 to 6 months and the tumor's responded, it's almost as though if the immune system's primed, it is primed, And having those gaps of treatment are usually not detrimental. We don't run into disease progression. And as I've shown, clearly, we're only at the tip of the iceberg. So, yeah, I think we're going to see a lot more immunotherapy and a lot more indications in non-small cell. Thank you.
Great, Shobhit, thanks for that update. And our final speaker today is Dr. Joanne Evans. Joanne is a consultant medical oncologist at Imperial College Healthcare NHS Trust. And Joanne's going to speak to us about the really important topic of managing immunotherapy toxicities. So, Jo, make yourself apparent, and over to you, please.
Okay, brilliant. Well, thank you. And thank you for the invite. When I was first asked to give this talk, I was really honoured. And then it dawned on me that I'd agreed to talk about the management of immunotherapy toxicities in just 10 minutes. So that's what I'm going to try to do, always up for a challenge. So I think that really, if you want to manage IO toxicity, you really have to have a good system and a good network behind you to be able to do so. And I would argue that the fundamentals of the management of immune checkpoint inhibitor toxicity can be represented by this triangle. So the things that we need are education, expertise, and guidelines. So education, we need to educate our patients about immunotherapy and immunotherapy toxicity and what to look out for themselves. We need to educate our front door, and that's our ED colleagues, it's our GPs, it's the acute medical take, as to the variety and complexity of these presentations. And we need to educate ourselves as well. Not all oncologists prescribe immune checkpoint inhibitors, but quite often we're all involved in selected take. So it's really important that we educate ourselves and keep our knowledge base fresh. So the next point on the triangle is expertise. And it's really important within a trust to identify oncology champions with an expertise in managing IO toxicity. It's really important to build an infrastructure for research into IO toxicity, because if we don't understand the fundamentals of why something's happening within a tissue, being able to alter management and hopefully in the long term avoid heavy-duty immunosuppression would be amazing. We also need to collaborate with our non-oncology subspecialties to increase awareness of IO toxicity and to gain understanding and help in managing these complications. Unlike traditional complications associated with cytotoxic chemotherapy, where quite often the answer is time, IO toxicity is different. It's not dose dependent, it's not time dependent, and quite often it's not something that we can manage on our own within oncology. Which brings us to guidelines, having solid guidelines within trust and for your satellite hospitals for people to understand how to manage the initial element of IO toxicity, including care order bundle sets, are quite useful for both initial management of IO toxicity and for the management of corticosteroid refractory disease. And I say that with some caveats because sometimes I think guidelines take away the ability of thought and a knowledge application, but on the whole, in order to have safe delivery of standard care, I think they're really important. And my phone has, there we go. Okay, so how can we identify IO toxicity? Because if you can't identify it, you won't manage it and patients will suffer. So there are different ways of trying to achieve this. We have some knowledge about timescales from all of the trials you've already heard about and from largely melanoma work, which was the real trailblazer for the use of immune checkpoint inhibitors. So we know that some toxicities are more common at some time points. As you can see, both of these graphs try to depict that. They're both taken from the ESMO IO toxicity guidelines. The first gives you some idea of when certain toxicities are most prevalent and how long they tend to be an issue for. And the second graph shows you actually there's quite a large range. So you could argue that, rash is seen early, but as you can see from the second graph here, actually rash can still become a problem some 12 months after starting. So timescales are useful, but not definitive. The other way to think of things is by having a good sieve, starting from the top to the bottom when you're reviewing patients. So starting with the CNS, have they got any weird CNS symptoms? Have they got overwhelming fatigue? Do they have brain fog? Have they got sterile meningitis? Have they got evidence of hyperthyroidism or hypothyroidism, pneumonitis, myocarditis? Working down. The second picture here is taken from cancer.gov, the American website, which depicts the common toxicities. So the blue circle being how common a toxicity is, and it's representing all PD-L1 and PD-1 antibodies, and the red circle being how catastrophic they can be. So how many of those toxicities tend to be on the higher grade end of the scale. So identification is difficult. For some things, it'll be incredibly apparent. If someone comes in and they usually open their bowels once a day and now they're opening their bowels 10 times a day, that's really easy. If someone comes in with fatigue or a general fog or some non-specific pains or aches, that can be quite a lot more challenging to try to delineate, is this IO toxicity or is it caused by another issue? Sorry, my clicker keeps turning my phone off. So here we go to the next slide. So you've identified your IO toxicity. Could I have the next slide, please? Sorry, my ticker's lost connectivity. So you've identified a toxicity that you're reasonably confident is caused by immune checkpoint inhibition. So what do you do with it? So this is an acronym that my DPhil supervisor used at me, I suspect, on an almost daily basis. And he used to say, with anything, KISS, keep it simple, stupid. And I think that was just his way of accusing me of being stupid on an almost daily basis. But there we go. So these are an example of generic general management advice from Clatterbridge on managing IO toxicity. Most institutions will have their own guidelines. And if you don't have guidelines, then you probably can't go wrong with the ESMO guidelines. So essentially, it uses a traffic light scheme, which I think is quite nice, and breaks things down into low grade toxicity all the way up to your high grade toxicity. And the basic fundamentals for whatever the toxicity is are generally the same. So for a EO-RTC CTC grade 1 toxicity, on the whole, you'd investigate, you do all of your tests to see if you are convinced that this is caused by the IO. You will monitor. So quite often these patients will need weekly, if not more frequently, to be seen either on your ambulatory unit or in clinic, and to plan. I would argue the most important element of management if you suspect IO toxicity is to plan, because then you can't be caught out. So for grade 2 and some grade 3s, so you would treat, and the mainstay of treatment for grade 2 and some grade 3 toxicities is oral steroids, typically 1 to 2 milligrams per kilogram of oral prednisolone. Also canvassing early specialist input. So if you've got a patient with a grade 2, grade 3 hepatitis, early discussion with hepatology, if you have that available to you, can be very useful. Investigate, rule out other causes. You know, if you've got a patient with colitis, is it CMV reactivation or is it a true IO colitis? Monitor. It's really important to monitor these patients. So where I work, anyone that's been started on oral steroids that are well enough to be at home tend to come up to the unit for the first 72 hours to make sure their toxicity is settling and to ensure they don't need to be admitted. In these patients, you admit the checkpoint inhibitor and plan for what would happen if things don't settle. For grade 3, or some grade 3 and all grade 4 toxicity, patients often need to be admitted. These are the patients who need high dose IV steroids, and typically again 1 to 2 milligrams per kilogram. So the number is quite easy to remember, it's the same, but this time methylprednisolone. So early specialist input. So all of our grade 4 patients get flagged to the right speciality within 24 hours of identification of the problem. And again, like the others, investigate, monitor, omit, and plan. So why do you need to plan, and what do you need to plan for? So the steroid wean is what we all hope we're planning for, and that's usually reasonably straightforward. When a patient has responded and they are being weaned, quite often the patient can be handed back to their own team to monitor with either regular bloods, a phone call, or reviewing clinic. Why planning is important is so that you're not caught out if a patient doesn't settle. So if at 72 hours of IV methyl pred, your patient's toxicity hasn't settled, then this is when we need to be a team. This is when we need our phone of friends, and this is when we need specialist advice. So this is usually the point when you're beginning to contemplate whether you need to use other immunosuppressive agents, and actually whether you need tissue to further try to delineate exactly what's going on. So in 10 minutes, it's incredibly difficult to talk about the management of all IO toxicity, but what I'm hoping I've done is cover what you really need and what backing you need to be able to manage these problems, and also to talk about how you may look at trying to identify them and the very, very, very top level management of these problems. So the things I've learned 100% is you need to have a phone a friend. And actually what I've learned for IO toxicity is you need to have at least 10 phone a friends. You need to have a hepatologist, a cardiologist, a neurologist, somebody in RESP, gastroenterologist, rheumatology, dermatology, endocrinology, renal, ophthalmology. It really is a team sport. So it's really difficult to manage a problem without specialist input. So although immune toxicity is new to them, the management of autoimmune disease, which these quite often emulate, is not, and they can be an incredibly useful contact, especially if a patient needs specialist input. Always think immune checkpoint toxicity if you have a patient on an immune checkpoint inhibitor, because if you don't spot it, you can't manage it. And some things can be really vague. Early aggressive management. So we have already heard that, steroid use can be associated with muted responses to immunotherapy. But equally, if you don't control the immunotherapy toxicity, then you have no chance of trying to re-establish them back on treatment. And this is probably one of the few times where actually you don't want to be cautious with your steroids. We have up to 12 weeks to manage IO toxicity before funding becomes an issue. And we have that long for a reason. So most of the failures of management that I have seen have been due to things like insufficient doses of steroid up front, or weans that are way too rapid. Know your local guidelines. And if you don't have them, or if you can't find them, then you probably won't go far wrong with the ESMO guidelines. Also, remember to warn patients about the risk of adrenal crisis, sick day rules, and all patients should be issued with a steroid alert card. Have a clear escalation plan in the notes right from the first review, as well as your steroid tapering plan. And their presentation is your window of opportunity for learning and for increasing your knowledge base. So if you don't know what you would do for that particular presentation, if they don't settle within 72 hours, look it up, document what you've read in the notes. It's a good way of learning, and it also makes it very, very clear if somebody else encounters that patient, what needs to be done next. So that really is a rapid run through of the management of immunotherapy toxicities. Thank you.
Thanks, Jo. That's a superb overview. And if I could invite all our speakers to show themselves, we're then going to have a brief discussion about various aspects. Please do keep your questions coming in. Jo, you talked about weaning of steroids. What's a rapid wean? What's a normal wean?
So I saw someone on the unit last week whose LFTs, it was a IO-induced hepatitis. LFTs really weren't falling, and I just happened to be on the unit because it was my week on. And I think that was largely in part that they were started on quite a low dose of prednisolone, certainly not anywhere close to 1 milligrams per kilogram. And they basically had their steroids brought down by 50% every 2 or 3 days. So I think you just have to be cautious. I think that, Shobhit said that the immune system, once it's primed, and that's good for response to IO, but it also tells you what to expect with regards to toxicity and complications. So I typically wean people really, really slowly. I make sure I know their 12-week date, so I know at what point we're going to have issues with funding, and I try to plan their wean so they finish around 4 weeks before that, and typically 5 milligrams of prednisolone every 5 days until they're at 5 or 10 milligrams of prednisolone before I start to think, will I re-challenge?
Brilliant, thank you. Question for Rafaelle. Would we have access to durvalumab EP chemo for small cell in the UK? Is it being considered? You saw that presented that lovely survival data. We haven't seen that for 133.
Yeah, so we did have access via an expanded access scheme in the past. So at present, I think you definitely have the Empower 133 regimen. You have to think about that the data for Caspian has got a longer follow-up. We haven't seen that kind of long follow-up for Empower 133. The Caspian was nearly 40 months. And I hope that we can see it with the Empower 133 as well.
Yeah, I mean, my understanding is I think AstraZeneca did not submit to NICE for the submission. So I'd encourage AstraZeneca to consider that. We certainly have a...
So at present, I think, as you say, is not available.
So Rafaelle, who should not get IO, chemo IO in small cell? Are you treating everybody, or are you being really, really strict only if they're a trial candidate? Where is real life?
So I am being quite cautious, and sadly, I wouldn't want to treat patients who are needing steroids to keep them afloat, because these are, PS3 patients would be, PS3 patients, would be much more unwell if they couldn't get steroids. I tend to be usually PS0 to 10 to 3 patients who are PS0 to 1, who have no absolute contraindication to immunotherapy. If they have active and symptomatic brain metastasis needing steroids, I would steer away because the data at present is not available. The patients with symptomatic brain metastasis were not allowed of any of the phase 3 randomized clinical trials. And realistically, I tend to make sure that patients have to be fit for chemotherapy first, for doublet, and I would try, as long as the organ function allows. If you got heavy burden of liver metastasis, the liver function tests are already deranged, I think you need to be careful, because you may develop hepatitis and you don't know if they're responding very quickly to bring down these LFTs. So I'm erring on the side of caution, I have to say.
No, that makes sense. And what about paraneoplastic syndromes at presentation? Is that a contraindication?
I would say short answer is no. Vast majority of patients who are walking through our door will have, paraneoplastic SIDH. As a minimum, you may have the paraneoplastic ACTH. What we know from retrospective series is that patients with paraneoplastic syndromes will not have worse immune-related toxicity, but you would hope that achieving a better response, you would treat the paraneoplastic syndrome as well as the cancer.
And with small cell, previously we were giving PCI and thoracic palliative radiotherapy in the REST or CREST indication. What's your position on that with small cell?
So in my practice, and I would say vast majority of colleagues at the Christie, we tend to refer for prophylactic cranial radiation because that was allowed in the study. The main relevant question is, should we give consolidation radiotherapy to the chest, because that was not allowed? I think the short answer is that we will consider them, because we know from the Nicholas study that immunotherapy can be delivered safely with high dose radiotherapy to the chest. This was a study in non-small cell, and the primary endpoint was toxicity, but that reassures me in a way that sadly we're not increasing the potential chance of getting immune-related pneumonitis, because that was the worry from a clinical point of view. So I have to say, we discuss patients on a patient-by-patient basis. I will make the referral for consolidation radiotherapy. If they have a lot of residual disease in the chest, we will do that. And I try and play around with the dates of the maintenance, making sure that I can still stick to the approved schedule in terms of funding. So I have to say, PCI, almost everybody, unless the patient is not keen on it, generally speaking. Consolidation radiotherapy most of the time.
Brilliant. Thank you very much. I'm going to ask Shobhit a few questions about non-small cell now. So, you said you don't give much second-line IO. So, there are different interpretations of the IO indications for non-small cell. Some people are giving IO almost to everybody in the frontline setting. Some people being very, very trial specific in terms of indication. So who should be getting IO in the frontline setting and who shouldn't?
I mean, from my perspective, based on the trial data, if we're talking performance status 0, 1, no other contraindications, whether you're a high PD-L1 or low PD-L1, for me to give the optimal treatment regime would be looking at IO in some form, either single agent or with chemotherapy. It's always about, do you, as we know, the high attrition in non-small cell, So you want to give your best option or treatment up front. So for me, really, I think the only group where I sometimes struggle is the squamous, because the squamous low PDL ones, the chemo backbone is not, it's tough love. And there are those who are sitting on that border performance stage, so I think I might break with that, and then I might just go with a kind of doublet chemo with the hope that I might be able to give them IO later on. But for me, if they haven't got a contraindication, it really is all in the frontline setting.
Do you ever start patients on steroids just to crank up the engine a little bit, and then consider IO bringing it in, or is that fool's gold? Really, you're not really winning in that scenario.
I don't think so, because I mean, to be able to prop somebody up with steroids, the steroids, it's an issue, and I think you're then in that territory, and the data's there that these are probably patients who are going to do bad anyway. So I think if they're bordering on the PS, that 1 stroke 2, I'd rather just, and I think they can take the treatment, I'd rather crack on, because I don't want to then be in the position where I'm also potentially detrimenting the actual efficacy of the treatment. So, steroids for me, no, not in that situation. But I think we, there's a real, we learned it the hard way. We'd almost primed our respiratory physicians. They were referring patients to us historically on decks, thinking they've done us a great deal because they propped the patient up, and we were getting these patients now trying to start them on IO, and they've been coming to clinic on 4BD decks, and we're like, no, I need to get this down quick. And they probably didn't need it. So no, for me, it's not something I'd advocate.
What about brain mets? Should we be giving IO to patients with brain mets? I mean, the trials allowed brain mets, but they had to be treated and stable. So if you've got brain mets, asymptomatic, should they all be getting whole brain radiation? I mean, brain mets, you've got asymptomatic and then you've got symptomatic. Where are we? What do we do in this scenario?
Yeah, I mean, I think exactly as you said, the trials excluded untreated brain mets. Blue text says not more on the non-symptomatic side. I mean, my practice isn't to routinely scan stage 4 or palliative patients unless it's symptomatic. So kind of that already sifts them into that category that if we pick them up, they probably are going to be symptomatic, and we're in the realms of having to treat them. But I think it's a complex field, because you are then, and I think there's that knee jerk of brain mets, steroids, and yes, we do want to go with it. But I think now more and more, I'm there looking at how much edema is there. Do we really need to be going in high dose decks? The lower we go in with, the quicker we can wean them off. So it really is, for me, trying to get it down. But I think it's an evolving field. I think it's an exciting field, because they were a neglected group. And there's data, small study, I think from Yale, looking at small brain mets and untreated, showing that these patients actually do, or a proportion of them can respond to IO. So I think, I think that thought initially where the brain is, a non-immune site, I think that's now going to be challenged. And I think we should be looking at this group in more detail, and hopefully more trials in that setting.
Thanks, and I'll bring Joe in. So does that reflect your practice, Joe, for brain mets? Do you treat everybody or nobody, or individual case-by-case basis?
So I think I have to acknowledge that where I work means I have access to things that other oncologists don't, and we have an amazing neuro-oncology service. I can get patients SRS reasonably quickly and can actually get them to clinic to start treatment with treated brain mets. Much the same, I don't routinely scan my non-driver patients with stage 4 disease unless they have symptoms, largely because we have such an excellent service, but I know that isn't the norm.
So, question both to you and Shobhit. So what about patients that present with autoimmune disease? That's a sort of relatively grey contraindication for IO. So Joe, what's your views and practice in patients with a baseline autoimmune disease?
I think it depends on what the condition is, what the history of that patient's condition is for them, the treatments they've had, whether they've needed lots of immunosuppression in the past, and just caution. So obviously what you don't want to do is to deny patients a treatment that actually has that amazing tail. And, we start talking about the C word, which for an oncologist isn't cancer, it's cure. And And I think you just have to be really careful. So I have treated people with autoimmune disease and really carefully consented them to what I could do to them. On the whole, I think we've probably been lucky and gotten away with it. The rheumatoid arthritis brigade now make me really, really nervous. We have caused some hideous disease flares in some of our patients that have taken considerable time to get back under control. So I think it's all about discussion with the patient, acknowledgements of the risks, the patient's own disease and natural history, and that whole, discussion, really important.
Shobhit, what's your practice there with these sort of grey cases? Are you hawk or dove when it comes to autoimmune disease?
In the middle, on the dolphin. I mean, I'd say exactly what Jo said. I totally agree with everything she said, and I think they are probably the group where, I might actually, if I'm extra twitched, I might go with the chemo up front and say, because the last thing I want to do is, scupper their whole treatment landscape and actually do them no good. And that's, if you do, touch wood, get them to that second line setting, you're almost in that, well, more of the I've got nothing to lose scenario. So I do, that is, but it's all on what is the autoimmune condition, how's the control been? Is it something that they've had no flare-ups for 10 years and they're not on any DMARDs, etc. So it's so individualized. And like you said, it's about having that conversation with the patient as well, and how much they're willing to put on the risk on the treatment as well.
Thanks. Ken, I'm going to ask you about managing acute toxicities. I mean, one of the problems we see is we've got patients on the 189 regime, pemetrexed, pembrolizumab, renal function gradually creeping up. Is that renal autoimmune nephritis? Is that pemetrexed? How do you manage these patients?
It's interesting, isn't it? Because I don't know what other centres did, but certainly through COVID, we ditched the pemetrexed and just put people on pembrolizumab monotherapy. So a lot of our trainees haven't actually got the working knowledge that pemetrexed can be a nightmare for the kidneys. So I think sometimes it's about engaging your renal team, and we have an excellent team at the Hammersmith. I've got a patient that had a biopsy on Tuesday on pem, who I'm not sure if it's the chemo or if it's autoimmune. I think sometimes tissue can be the answer, but it's about making sure you've considered every eventuality, isn't it, and every contributing factor. And
what about some of the rarer toxins? How do you identify these? And I saw the NCI really say, in your figure in your presentation, the rate of peripheral neuropathy in the NCI figure was really quite high.
Yeah.
It doesn't really sit with me, but maybe I'm not asking the right questions then.
No, I think you're right. And I meant to say that when we went through. I think I've probably seen one case of convincing peripheral neuropathy secondary to Pembro. So some of those things, and I see a lot more pneumonitis, and that figure suggests that they're documenting. I think some of the rarer things can be really difficult. So recently I had a patient in clinic with overwhelming fatigue, small cell on maintenance of atezolizumab, really quite fit, performance status 0 up front, had a very, very manual job that he managed to keep up with for the first couples of treatment, and then just crashed. So, the first time he had the usual thyroid screen, and in the end, I ended up sending absolutely everything, and he had no testosterone, but everything else was okay. So I think sometimes it's just about throwing money at the situation in terms of the access to tests that we have. And again, I wasn't very clear if that was just, his small cell or whether it was the treatment. I think sometimes it can be really, really difficult. Some of the myositis kind of syndromes are really difficult as well. People on GCSF that are now, on chemo IO that are achy. I think it's a real minefield, and sometimes it's time that tells you there's a problem.
That's right. So it's a really good point. So being very twitchy and keeping an eye out for these issues. So with that, it's gone past. We've reached our allocated time slot. I'd very much like to thank our expert speakers for their time, information. I think I could go on for another half an hour, at least not another hour, picking your grey matter for these pearls of wisdom. Perhaps we can do that at some point in the future again. Thank you very much for our audience, and I look forward to seeing all of you virtually at the BTOG annual meeting, which is on the Thursday and Friday, the 27th and 28th of January. in 2022. Do register. It'll be great to see you there, and we'll be discussing all of these issues in greater detail. Thank you for your attention, and as ever, thank you for your support.